Hello and welcome to the Royal College of Speech and Language Therapy and Health Education England joint funded webinar on delivering entry-level dysphagia competencies into pre-registration education and training. This exciting innovation is something that we need to do as UK speech and language therapists, and this webinar is an international overview of how it's been done elsewhere and how we can learn from it before we move on to our journey. Before we go any further, I wanted to introduce myself as the chair of this webinar. My name is Judith Broll and I'm Director of Professional Development at the Royal College of Speech and Language Therapists. And as a Royal College dysphagia advisor for many years, I absolutely understand the need for changing the way that we deliver training for pre-registration therapists. Not only has it been difficult to recruit into band 5 clinical roles from my acute posts, because the clinicians don't have the skill set, but I absolutely see the need to bring our services up to date with the rest of the world. I would also like to introduce Louise Borges, who is my partner in crime in this pilot study, and she's the Professional Guidance Manager at the Royal College of Speech and Language Therapists, and she is on hand to help answer questions this evening. Before we introduce our esteemed presenters, I'm going to hand you over to Becca, who's going to run through housekeeping with you.
Hello, welcome everyone. So as Judith just mentioned, there is a chat function at the bottom of your screen, so feel free to get in touch with us if you're having any technical issues or anything. Also, please do ask any questions at any time during the webinar via the Q&A button to any of our speakers. There will be a section after the presentations for you for those questions to be asked. This event is being recorded and will be available on the RCSLT website very shortly. And you'll receive a short survey after the event. If you could kindly fill that in for any feedback, we'd be very grateful, and enjoy the webinar.
Thank you, Becca. And it is now with great pleasure that I would like to introduce you to our three presenters. Firstly, we are going to hear from Beverley Harden, who is the Allied Health Professions Lead at Health Education England. She's also the Deputy Chief Allied Health Professions Officer for England, and in her spare time, she's a visiting professor at the University of Winchester. We are also delighted to have with us the Professor Liz Ward from the other side of the world, which is tomorrow morning for her, who's the Director for the Centre of Functioning and Health Research at the Metro South Hospital and Health Service, and the Conjoint Professor at the School of Health and Rehabilitation Sciences at the University of Queensland. And finally, I'd also like to I'm delighted to introduce Áine Kearns, who is the Lecturer and Regional Placement Facilitator for Speech and Language Therapy at the University of Limerick. I think what would be useful is just to give an overall overview of the project aims and to introduce how this new Health Education England funded UK-wide project, which is led by a college, will benefit the UK-based speech and language therapy dysphagia services. And we are going to be hearing and learning from our international SLT colleagues who've already embedded entry-level dysphagia competencies into their pre-registration education and training. Not only do we need to align our training, but also it's an opportunity to hear how they did it and to learn, take their best bits and learn from where they might do things differently if they could go again. So the objectives of today's webinar is to get an overview of the project that we're about to embark on and what that means for you, to also learn about how this work has been delivered in Australia and Ireland, and to provide the opportunity to ask questions about this work and also hear more about how you can get involved. So, how did we end up here? It's a real case of stars aligning, really. I've been in post since last November, and in my third week I was sent on a plane to Orlando to meet colleagues who are working with us on the Mutual Recognition Agreement. Now, for those that don't know, the MRA is a group of speech and language therapy professional bodies from English-speaking countries and we work together to recognise each other's education and training qualifications. This allows for equitable movement of speech and language therapists from those countries across the world. And I'm sure that many of us on this webinar have had the experience and the pleasure of welcoming clinicians from around the world, and sharing skills has been a real benefit for all of us. Royal College is a founder member of this group, and so it was with interest that I attended this meeting with Louise, where it was said very clearly that actually UK clinicians are lagging behind the rest of the MRA in not being able to deliver dysphagia trained therapists into their workforce. And we went away saying we need to do something about this, and I came back with my tail high thinking this is our mandate really, to start looking at how we can change this work. At that point, I started talking to Beverley and her colleagues at Health Education England to see how they might be able to help us to fund this work and support us, as well as with colleagues at college. And then COVID hit as the third piece to this puzzle. And I think however awful it is for all of us, what it did is to highlight really that there aren't enough proficient speech and language therapists with dysphagia skills to be able to support the workforce in redeployment or with patients needing our skills. And I think it became clear that as a profession, we are obligated to deliver entry-level dysphagia competencies to ensure we optimise safe patient care within the 21st century health, education and social care environment. So with Beverley's support and with college support, we put together a bid to Health Education England. And at this point, I would also like to thank our colleague Emma Ormerod from the University of Manchester, who was really key in helping us push the bid over the line. And we now have some funding to deliver this piece of work. So what is this piece of work? So the overarching aim is to deliver entry-level dysphagia competent graduating students from 2024 across the UK. And I know that the money comes from Health Education England. It is absolutely crystal clear that this is for all 4 nations. I just also wanted to make a point here that we are absolutely mindful that there are already places, HEIs and clinicians who are already delivering this training into their workforce. But this is an opportunity to make it uniform and to ensure that whether you train in Strathclyde or Exeter, that everybody has the same level of training when they come out of university. This is absolutely a triumvirate of people working on this with academics, clinicians and HEE, and we're doing it in 3 phases. The first phase is to write and to deliver entry-level dysphagia competencies by February 2021, which is actually galloping to the finishing line as we speak. Just as a quick plug, the application for the 2 lead authors we need, 1 academic and 1 clinical, closes on the 23rd of October. And if anybody is interested in applying, then please do, there is time and there's information there, or email Louise at the moment and she'll be able to send you information. These competencies are going to be aligned with the entry-level competency framework that our colleagues very kindly in Australia and the Republic of Ireland have shared with us. And I think this is a really good opportunity to align what we do against what has already been proven to work in the real world out there for a long time. We not only are looking for lead authors, but we're also looking for members to join us on this journey. Again, if you'd like to join us as one of the working party, please see the attached link. We're going to be writing an article in Bulletin, which is due out in November, and there will be a consultation on these competencies in January. So please, if you're interested in hearing that early, to sign up there. And these competencies will be delivered to the HEIs by middle of February next year. Now, this is because the HEIs then will be asked to self-assess against these competencies to see where they're already delivering training, and also where they might need some support to raise their input to make sure that they can align to it. From there on in, there will be focus groups for clinicians and HEIs, and then we will move forward. So watch this space for what happens next. And it is now with great pleasure that I'm handing over to Beverley Harden at Health Education England to hear how she's going to be supporting us with this work.
So thank you, everybody. Delighted to be with you tonight. I'm incredibly excited about this work. Back in 1998, I ran a multi-professional service in Southampton and was absolutely astounded to find out that speech and language therapy was not covering dysphagia in its undergraduate training, and that we had to then access those training programs as a postgraduate course. And I think the challenge for me with that was it meant that the staff that I had were not able to meet the needs of my patients and of the populations that we served at the point of graduation. And it just put increasing numbers of obstacles in the way when you think of the challenge of accessing funding, being able to release staff, and the absolute pressing need of service to have needs met in the moment by the team wrapped around them. So I am utterly delighted. 12 years later, Judith phones me to say, how about we do some work together? So on a personal note, I am delighted. I've also been really interested, as I've told people about this work, how surprised everybody is that it is not part of the undergraduate curriculum. And so, you know, a huge challenge to the workforce. I respect that entirely. Huge challenge to the profession. I respect that entirely. But together, we can achieve great things. And I am absolutely determined that we will wrap around the college, wrap around you and support you to do the best we possibly can to get this work landed well and at an appropriate speed, not too fast, not too slow, but at a speed that delivers for the patients that we serve. Next slide, please. So HE exists for the purpose of being able to support the educational reform of the professions as they evolve. Our job is to keep pace with you, drive and push the boundaries of care. So we are creating 21st century speech and language therapists, the kind of person that you want looking after your loved one when they're in their moment of crisis. I want a 21st century speech and language therapist to appear by my mother's bedside post-stroke to look after in her moment of need. And as Judith says, we saw with the first wave of the pandemic and many colleagues currently experiencing the same, the absolute necessity of speech and language therapy in that whole COVID journey for people. Never before has your profession been so thought about, so talked about, and I think so well understood, which is a great achievement, I think, for the profession, but one we have to capitalise on together. And in all the preparation for this piece of work, it's very clear to me that so many of you are active in this space already. There are clinicians driving the uptake of these capabilities. We've got universities squeezing things into the edges of their curriculum to really try and deliver for populations. And the aim of this work absolutely is to build on those assets, build on your learning and create something very, very, very magical together. Not throwing babies out with bathwater and absolutely not reinventing at this point. So please get involved in the work that Judith was alluding to, whereby we can bring all of that learning together. And it's not just about people who are violently in agreement with each other either. We want the people who find this really challenging to come join the journey with us to help keep everybody anchored in the challenge, but also the opportunity of this work. So it's really important that we link across education, service, across the system to bring together everything that we have got that we need to make this work, because we only achieve this together. And very clearly, as Judith says, this is about all of us in the UK together driving change for populations. Next slide, please. Thank you very much indeed. So HE has a national footprint and a regional footprint, and clearly the college has a similar setup with the ability to work across systems. In the allied health professions world, we have the developing infrastructure of AHP faculties and AHP councils working across systems to bring together academia and service to deliver. So when you're looking at how some of this may be operationalized and you're thinking, I don't know how I can do this on my own, I don't want you to think that you are on your own. You're part of a system who can help and support and to look at how we drive change together, not in isolation. We're doing lots of things to try and help and support. We're looking at how we can make sure there is absolute transparency around placement tariff and the ability to then look at getting universities paid for simulation-based placements that make up clinical hours in universities so that we can absolutely ensure that money follows activity for placements. I don't want anybody to think that we do not value communication as much as we did when we start to think about how this fits into the curriculum. The communication skills of the speech and language therapist are absolutely vital to that 21st century speech and language therapist, but so is the dysphagia training. So our absolute challenge as leaders together is how do we create an environment where you've got a packed curriculum already, that we appreciate the need to understand how we fit in the dysphagia training that is required alongside the absolutely vital and incredibly valued communication skills. Your USP is twofold, not onefold. How do we create space to absolutely drive the ambition, but also the absolute value add of the speech and language therapist in the team? Next slide, please. So I put it to you that this is the evolution of your profession. This is just what happens. As the whole nature, the whole definition of a profession is that we continue to evolve over time. We're at that point. I absolutely admire and respect the college for driving this work. So thank you, Judith. Your leadership is incredible and so valued. And as we advance the role of the professions at the top end of what a speech and language therapist can do, we have to advance every other level of staff in that team too. And that means advancing the level of training of the undergraduates as part of that continuum. So this is part of all of us realising our potential. And you mustn't forget that when the thermometer was invented, only a doctor was allowed to use it because it was such an incredibly important piece of equipment. And that just gives us, I think, a fantastic anchorage about the fact that we do as professionals evolve. And that is the magic and beauty of what we do as we craft our future workforce together. So I commend the work to you. I'm grateful to the college and delighted to have the privilege of introducing Liz Ward to you next, who's going to carry on and tell us of the experience of actually making this happen. Thank you all.
Thank you, Bev. And so Rachel is going to assist me with slides. So while Rachel's pulling up the slide deck, I just want to say, so I'm coming to you from Australia, where we have included dysphagia training at an undergraduate level for over 30 years now. So it's very much a core part of our curriculum and our program. So I'm speaking to you with the perspective of our program at the University of Queensland. So Rachel, you can skip that slide. Next one. Yes, so our training in our program, we train both students at a Bachelor of Speech Pathology level and a Masters of Speech Pathology level. So the Bachelor is your typical 4-year program. Next slide, please. And then the Masters is a 2.5-year program that people come into when they've already completed a previous bachelor's degree in some other profession and then come in. So we have the 2 programs running simultaneously. Next slide, please. So in our program, in our curriculum, so we cover all of the range indicators. So speech, language, fluency, voice and swallowing disorders are covered and trained to an entry-level capacity for our students. And throughout all of our program then are weaved all of those issues of anatomy, linguistics, psychology, etc. Next slide. The important thing for our program is within the University of Queensland, students commence clinical placements from the very first year of their program. So clinics are embedded within every semester of their degree, and so they go out into sessional and or block placements throughout the whole of the course. These are organised by our CHLMs, our Clinical Education Liaison Managers. We have over 200 placements we can spread people across, and we also have a specialised tele-rehabilitation clinic where we also offer dysphagia work in that, and then a simulation program that we have across a number of range indicators, including dysphagia, that I'll talk to you about today. Next slide. Just as context, the speech pathology training programs in Australia are all accredited by Speech Pathology Australia. We originally were working and mapping our skills against CBOS, the competency-based occupational standards, but for you now, the relevant document to look at is our professional standards that states the minimum knowledge, skills and attributes that our students are trained to and that a clinician must be available to do in the workforce, and the links for the website is at the bottom of this slide. Next slide. So undergraduate, we're focusing on the dysphagia part that is achieved through 3 elements. So we have both coursework, simulation and clinical practice. Next slide. So the coursework is completed, is designed to meet our Speech Pathology Australia Dysphagia Clinical Guideline. Again, the path to find that from the Speech Pathology website is on the bottom of this slide. Next one. And most importantly in that document, what you can see here on this slide is the information about what is stated about an entry-level clinician, and that is all clinicians, including entry-level, should have the appropriate skills to assess and manage non-complex cases. So that is the important parameter. And then when you look at that table of expectations, that's what we need to train our students to be able to do by the time they get into the workforce. Once into the workforce though, if they're managing anything but a non-complex case, naturally then high-level supervision is required. Next slide. So the coursework content in our course, the undergraduates and the master's students completed, of course, different times of their program, but they are in the same class. They complete 42 hours of contact teaching, and then our master's course completes 12 hours of simulation. Next slide. So the simulation component, this is an important part of our program for the master's students to give them enough skills to feel comfortable to be working in clinical practice. We have 12 hours of simulated learning that covers interviewing, screening in the clinical swallow exam, therapy, paediatric feeding for non-complex cases, and then we do have a tracheostomy management sim, but it's of a non-complex situation. So it's a patient who's already cuff deflated with a speaking valve on during a clinical swallow exam. So I just want to show this little video now. It's a YouTube video, so you can see it any other time. So Rachel, if you're able to activate that. This covers the speech pathology dysphagia program, sim.
So a number of studies have shown that speech pathology students are actually very nervous and have heightened levels of anxiety about going into clinical placements and working with people, adults or children who have swallowing disorders, which is the condition that we call dysphagia. So since 2014, we here at UQ have developed the dysphagia simulation program to add into the academic program. This allows our students in a safe learning environment to practice their clinical skills, their communication, their manual handling of patients, to practice all of that in a way that gets them better prepared for the clinic.
Working in the acute care at the hospital or working in the high dependency unit can be quite a confronting experience if you've never seen anything like that before. And the sim-based learning has really given us an opportunity to develop the knowledge, the skills, the attitudes that you need to be able to practice as a speech pathologist without putting patients at unnecessary risk. So it's been a phenomenal learning experience. So all of our simulation sessions were held in the simulation ward where we have 10 different beds with the hospital setup. So we got the experience of seeing what a speech pathologist would look like in the real world despite actually being there. We got broken up into different groups, and we always had one that was pretending to be the patient, one that was the clinician, and often the other allied health professionals that we'd worked with.
Some of the activities that we've done in this clinic involve basically working with the experts on interviewing techniques. We've also done some therapy planning with them. They've also helped us a lot with conducting clinical swallowing exams, which has been really amazing. And we also worked on a patient with a tracheostomy, which was definitely an experience. I really, really enjoyed that. The clinical swallowing exam, we got to basically interview some patients, talk with them about what they're experiencing. We also got to feed them different fluids to see how they're coping. And then we got to trial some techniques that might help them swallow a bit better. So with the infants, we got to basically practice working with them and seeing how to best hold them, to position them, as well as, you know, different types of techniques that might work, the parent feeding them. The fact that we got to learn about all this theory in class, in lectures, and, you know, you don't really get to actually apply that knowledge. So being able to apply everything that we've learned with experts around us, you know, giving us some feedback, giving us some tips that, you know, different types of ways that might be, some things could be said better, was really, really helpful as a student clinician. So it's definitely been a great experience, this whole simulation.
We've been researching this program since we began it in 2014. We have found all of the students believe in the value of simulations. They have enjoyed working in simulated environments. They feel that it has increased their knowledge, their skills, their confidence, and has significantly reduced their anxiety. So it's become a very valued part of the UQ learning experience.
Thank you, Rachel, for doing that. And then if we can return to the slide deck. So we use the simulation both to practice, and then we also use simulation opportunities to do OSCEs, so structured exams. And so our students do a dysphagia, pediatric dysphagia feeding OSCE as one part of their assessment component as well while they're in the undergraduate. But so Rachel, if you can go forward 3 slides. Keep going. So, so what was on some of the previous slides? So essentially our students do the sims as practice. They have sim OSCEs exams. So it gives you the opportunity to really examine and test and see that the students are competent in a simulation environment. But then in addition to that, all of our students go out onto clinical placements and they all receive an opportunity to work in a dysphagia environment, and they are assessed on their competencies as well in the clinical practice. So we have both academic, we have simulation, and then we have clinical level testing before they graduate to make sure that we feel that they are competent in this field. But then once they get into the workforce, then that's where workforce competency training comes in. And we, so once you're in the workforce, you do the additional workforce training to get competent in video fluoroscopy, fees, tracheostomy management, etc. But base level competency is achieved at the undergraduate level. Next slide. Okay, that was the end. So I'll hand over to Áine now from Ireland to give her perspectives.
Thank you very much, Liz. So I'll just wait while I'll start talking when my slides are coming up along, but just to give you an overview of the work that we've done within an Irish context. And we have introduced dysphagia into our pre-registration competency development since 2010. And I actually work, so we can actually flick on to the next slide there. I actually work as part of one of the practice education teams within the 4 universities that train speech and language therapists. So we have 3 bachelor's programs in the universities, and that's in Galway, Trinity, and in Dublin and in Cork. And I work on the master's program in the University of Limerick. And so that's a 2 years master's program, professional qualification. All of the programs are RCSLT accredited, and that's where our original accreditation body came from. But since 2014, we are also Coursework accredited, which is our registration body within an Irish context. When we set about introducing dysphagia competencies at that pre-registration level, there was very much a drive from IASLT, from the HEIs, and from the service providers to come together in order to work through the kind of the workload that was involved in terms of setting up the competencies, but also in terms of embedding that within general practice. So if we can move on to the next slide. What we have done at the start, we set out a pre-entry clinical education program, which set out the criteria from the move of introducing the competencies into pre-entry level from 2010 to 2014. And we had an overview of our competency ratings across all of the universities, all 4 of us, we are very small, but we had an overview in 2015, a review of these. So dysphagia is now embedded within that common competency form, which makes life a little bit easier for us as well. And that was kind of a stepped approach. So if we can move on to the next slide, I'll just talk through that kind of history. So as I said, the HEIs, ISLT, and all the service providers did come together initially. I started my role in practice education at the end of 2009, and I came in towards the end of that initial planning phase as it moved into the on the ground placements and as well as the academic provision for students. We had a large drive in 2010 where we had post-qualification dysphagia training for practicing clinicians with the view to building capacity within services, and also with the vision of looking towards those future practice educators that would support placements. So that was actually quite a drive that was funded for existing clinicians that were practicing. And then, as I mentioned, we have had a kind of a stepped approach where the initial 4 years looked at very separate clinical education criteria for dysphagia. And it is now far more combined within the student clinical competency forms, which is tracked across 3 levels of placements that all 4 universities use. Individual universities have done different things in terms of their own investments in staffing, timings of academic content, how we've embedded that into modules, and also different kind of practical initiatives and assessment types that we've used. So there are different approaches. Some use more OSCEs, some use more kind of case-based. So we have some variation within that, but there is the common competency form used with all 4 of us. So if we move on to the next slide. And it's just to kind of give an overview of prior to 2010, we did cover the academic content around dysphagia in all 4 universities, and that also included practical sessions. And students would engage in placements that also had exposure to dysphagia, but they weren't getting the kind of credit for that exposure. It didn't result in qualifications postgraduate. But since 2010 onwards, It has become more embedded throughout the program. So we still have that, core kind of module around dysphagia, but we also have additional aspects of dysphagia embedded in like complex cases in other modules, in terms of stroke, in terms of special populations. We've added in additional pre-placement learning opportunities, and then also a placement. So from our context, it's across all of our placement levels. If there's opportunities for dysphagia, students are credited for that. And we have at times as well needed additional top-up placements that are dysphagia specific. And that's something I'll just touch on as we go a little bit further in terms of some of the kind of constraints around that. So the kind of knowledge and skills across the academic and practice education kind of criteria have, there are variation within it, but as I said, we use this common competency form throughout the 4 programs. And if we just flick on to the next slide. So we've talked, I suppose from my perspective and my core kind of role initially was looking at placement provision, placement support. So we needed to kind of prepare students before they ever got out on placement in terms of the expectations for them. And so doing a little bit of like what Liz has talked about, we did a little bit around kind of simulated sessions. We also did lots around video observations, embedding things like problem-based, case-based learning activities. We also prepared students in terms of, I mentioned that separate clinical education criteria came as a kind of a handbook, and in UL we actually embedded a huge amount of additional resources for students within that handbook so that they could have extra opportunities for self-directed learning. It's a master's program, so we were encouraging students to actually be involved in additional kind of role play activities, doing kind of narrated reflections. So there was a lot of preparation that we had to put in before students got out on placement. If we move on to the next slide. And so in terms of the factors that kind of influenced our placement provision, we have an existing kind of situation where we have practice tutors in a number of hospital settings throughout the country. So there were already some close relationships between the universities and the placement sites, and that continued to kind of grow. And those practice tutors actually helped to really kind of act as models and help to guide the provision throughout other placement provisions as well. And we provided additional training for practice educators as necessary, additional resources for students before and during placements. And as I said, that initial student kind of pre-placement preparation were really key facilitators for placement provision. But we did meet a number of barriers. There's no point in saying that these things don't exist. And one of the big things for us was that move from that post-qualification hours-based approach to this competency-based development. We got a lot of questions at the start around that. We get nothing of that now, but that was an initial kind of resistance at the start. There were challenges with capacity for placements and also the practice educator confidence around taking over that role. We needed to kind of work with that as well. We had issues around timings of placement, both within the academic program. So our dysphagia module originally was actually towards the end, leaving little opportunity for placement. So we had to kind of rejig that around a little bit. And we also have overlap with other universities, and we do have close connections. Our students will go out on placement sites where students from Trinity or students from Galway will also go. So we needed to try and, kind of tease some of that out as well over time. And if we move on to the next slide. So in terms of some of the impact that I'm seeing now, in terms of the competency now being part of the pre-registration qualification, it really is now that we can see that dysphagia is just part and parcel of the clinical skills and knowledge for SLTs. And we've seen a build up in capacity in services and across services. Even in my own area, when I started in my role almost 10 years ago, or just over 10 years ago, we had a regional hospital with very, very small speech and language therapy team. That has expanded, and we're now even getting expansion within services in that hospital into paediatric services. That's an area we still need to work on as a profession in Ireland, but actually we can really see benefits of this because we have new graduates coming out. They are able to go onto the graduate panel and they're able to move into jobs in any area. So that's been a real advantage for us, but it's taken time to get there. And if we move on to the next slide. And just in terms of the factors that have helped us with kind of engaging within the profession, within the university. So I mentioned that building capacity at the outset, so that additional training. really kind of helped to kind of sow a seed of further service development down along. Now, obviously that came at a time as well where we were kind of, you know, sitting in the middle of a recession, but we have seen change over a number of years, and we are seeing greater capacity now. We had quite a lot of collaborative engagement facilitated through RCSLT, but also with the universities and with stakeholders from services coming together in those initial stages, and then also the national workshop that we held in 2014 that saw the move from the kind of segregated competencies into more combined competencies. There was a lot of engagement from different stakeholders at that point. Initially, I would say from our perspective, we saw that the final sign off, and I use the kind of air quotes of like if students were competent or not, that was one that was challenging for practice educators, and often sat kind of in the university. You know, we get a lot of people linking back in with us, wanting us to kind of support and make sure that everything was, that they were kind of signing everything off as they should. We are now seeing that as it's part and parcel of the kind of national student clinical competency evaluation with practice educators, it is now just rated as a, you know, as part of that. So we don't have any of those challenges that we would have met at the beginning. And in terms of supporting our clinicians with training, with additional resources around that competency development, that was key at the early stages. And then also the kind of modelling and guidance that we got from practice tutors showing that this can be done, and that kind of filtering down along. So that support was really quite helpful. We also see now we see opportunities in all placements where there may be a dysphagia caseload. So even if it's a small part of a placement, students can get some credit around that. When we are asking for our placement offers, we have an offer form that asks, is there opportunity for interprofessional education? Is there opportunity for dysphagia? So that we're tracking that right from that early stage, and it's kind of on the mind then of clinicians as well when they're offering placements. And if we go on to the next slide. And just moving on to some of the challenges as well, I've touched on these. So as I said, we had that kind of concern around the SLT's confidence, practice educators' confidence, and their expectations for students. So thinking about how it needed to be equivalent to the post-qualification, while actually, no, it might be dependent on the student's level within the placement. So that was an area that we needed to kind of tease out the different expectations at different placement levels. And also, as I said, that capacity issue at the start, we did have a huge issue in terms of capacity, and we needed to facilitate additional top-up placements for students to ensure they got sufficient dysphagia experience. That's something that actually is not as much of an issue now. And also at the start, we really needed a lot of that pre-placement preparation in terms of time, resources. That was a challenge for us. That's a little bit less of a challenge now in that it's more embedded in. I mentioned about the timelines for placements and, you know, where the modules sat within programs and how we have overlap. That's still something that we have to tease out at times. And I've mentioned as well the capacity in terms of that initial staffing. We've now seen a huge change throughout the services nationwide. We're seeing greater capacity. And interestingly for us in UL, we have found that COVID-19 has had less of an impact on our placements that actually provide dysphagia services in comparison to other sites that placement offers have been withdrawn now, where services have been redeployed and things like that. So we're actually finding that those that are providing dysphagia are more consistently offering now in this, you know, new environment, and it is done holistically. So it's not just dysphagia, it's combined in with the communication that may be part and parcel as well. So it becomes more natural. And the next slide. So just in terms of some of the kind of final, I suppose, helpful tips that I feel like I want to pass on based on my experience, there is an element of being over-prepared. And sometimes we've gotten rid of quite a number of initiatives that we brought in and we've refined them down. But at the start, we did put a lot of resources, a lot of work went into it, and we did reap the rewards of it. So there is an element of putting that extra work in now will pay off. I recommend thinking about breaking down everything into like looking at the placement levels, the expectations for students, the different roles and responsibilities across placement sites and universities can be really helpful. And look at small as well as larger opportunities. So where students are going out into a primary care placement, but there are therapists there working with a dysphagia caseload, they may have an opportunity for exposure there and should be credited for it. And thinking about resources that both students and practice educators can have in order to support the competency development is a key thing as well to consider. And if I was to do this again, I think a collaborative approach where there may even be an idea of a repository around resources would be really useful. And we kind of missed a trick at the start, and that's something that actually, as the 4 universities, we've been coming together now and talking about this in light of COVID-19. So that might be just something for you to consider at this point going forward as well. So, and then the next slide, I just want to say an opportunity to thank you for listening to me and best of luck with this. I firmly believe this is really it's great for the SLT profession because we're able to look more holistically at our client assessment, client management, and I just think it's really the way forward. So I'll pass back to Judith. Thank you.
So I'll start again. I just wanted to thank all of you for that whistle-stop tour through where we've been, where we are now, and then where the opportunities are for us in the UK to end up. And I do think that hearing what our possibilities might look like in the future, for me personally, has really helped me work out what I'm focusing on now, and hearing what a very positive and exciting place it is, but also hearing we've got quite a long journey to get there, but hearing the tips and the things that you might do differently. I've got huge things to take away and lots of lists. I'm also aware that we are also running over time, and I apologize because I think we've been on lag and there's been challenges with technology, but I'm hoping that we can just have a couple of questions because there's so much rich data that we'd love to get out of you all while we've got the opportunity to have you here today. I know there have been questions flying in, but the one or two that I would just kind of cohort together, which I might open to any of you really, well, probably to Liz and to Áine, and then I've got some questions for you as well, Beverley, sorry, about what we can deliver through Mental Health Education England. Something that's coming up, there's one really themed question from HEI is about how we can cram in any more stuff into the curriculum around dysphagia. Some universities, some HIs have already been doing it, and some will have to really start to think about rethinking their whole curriculum in light of this, bearing in mind that the competencies that we will be delivering, asking to deliver against, some of which may also have some competencies that we can take out of dysphagia that are already happening around record keeping and how we talk to patients and all that stuff, but the key dysphagia things. And I wondered if either of you, who'd like to start with that question? Otherwise I'll do pointy. Can I start with you, Liz, in terms of what your suggestions might be, and then I'll ask Áine to catch up.
Yeah, there's no easy suggestion. As an academic, and I've been an academic for 30 years, I know that every day there's something else you've got to squeeze into a curriculum. There is nothing you can do except a major overhaul. When you're trying to bring in something as large as this, you will have to just do a strategic overhaul of how the program runs and how it's taught. There isn't a simple answer. There's nothing you can drop. You just have to find new ways to teach, and then a lot more independent learning. So class time becomes prioritised for different things, and then there's independent learning sides that go with different elements of the program.
That's really interesting, being more creative about how you deliver that and maybe thinking about new ways of doing it, especially in light of
yeah.
That's really helpful. Thank you, Liz. Is there anything you'd like to add to that one? Yeah.
I think one of the things that I would be aware of is really identifying what's already been covered, because I think in some of the universities, they are actually covering quite a good bit of academic content around dysphagia. That is something that's been in their for potentially a number of years, but may have had no space where that's going to fit into any additional content or into placements. And that's the part that may need to be rejigged. So there's almost a stepping back and see actually what is there right now. And I think then it's pretty much like what Liz is saying. It's like seeing how that fits in afterwards. So we would have covered the module that we had previously run for students was also the module that the clinicians coming for post-qualification training cover that academic content, but our students got none of the placement or practical criteria and activities. And so that's the bit that we had to add in. So it is then about being creative, I think, yeah, and that piece about being independent as well, and but we don't have to handhold everything.
Mm-hmm. Absolutely, and doing things a bit differently as well, absolutely, and just thinking. So it's I actually am not under no illusion that it's going to be easy, but I do think that it is important. So it is thinking about how to work differently, isn't it? That's what we're all doing at the moment. I'm not saying it's not happening. Let's face it, having to put whole courses online within 6 months is no mean feat, but it shows that we can do it already. So it's about just taking that forward in a different way, perhaps, I think. So that's just something for us to think about. And then on the other side of that, we're getting quite a lot of traffic and questions about the practice educator part as well, which is the other side of the same coin in my head. And and I think something you said, I think we both said actually, it really chimed with me, is how to move from these are the number of hours you need to these are the competencies you need. And that's quite a big head-based change, I would suggest, for educators, both academic and clinical. And I think the two questions I have around practice, I think clinical practice educators, or they're called something far grander in Australia, I can't remember what you called them, Liz, but having somebody to link between academia and clinical is key, and that's something we need to think about. But then how do we support the clinicians to feel confident about signing off those competencies? I wonder whether, Áine, we could start with you.
I think for us, one of the key things that we would have found out, like there was, quite an initial concern, and a lot of it was around, okay, let's try and understand the expectations here. So our criteria is very much like what Liz was talking about in terms of that non-complex management of non-complex dysphagia cases, and that's what we're aiming for at entry level. And so we would have, where we have a number of different competencies throughout, talking through kind of hypotheticals that might fit those competencies, what you need to see in terms of clinical practice. So we did a lot, and that's what we're saying about that over preparing. We did a lot of kind of hypotheticals around, this is what you should be looking for in this particular competency. These might be potential activities that might reflect some of that competency development. So I think there's a lot to be said about having a kind of a pack ready to support where clinicians are unsure about what that, I suppose, that level, that expectation might be. So we did a lot around categorizing that at the 3 placement levels. So obviously, if somebody's going out on a novice placement, our expectation is that they're going to still need, a lot of direction there, and what that looks like in terms of, a clinical assessment, bedside assessment, versus at entry level. So we did kind of we gave categories around all those things. So there's a bit of work involved, but we found that over time, it just became part and parcel of, that's what you're expecting if, somebody's assessing a voice patient. This is the area that we're looking at in terms of at that entry level. And similarly for dysphagia. So I think it is about that kind of giving clear criteria around it as well, then gives confidence to clinicians.
I think
I'll add to that we did a huge amount of training when we moved to competency-based standards 15 something years ago. I mean, it was a large amount of training, large amount of support for our clinical educators. That was the only thing that could be done. Just you had to handhold and bring people through that transition to stop thinking hours, thinking, wow, they've done 5 hours, they're done, versus are they competent? They might have only done 4 hours. It took a lot of work. So you have to invest heavily in that.
Yeah.
That's really interesting to know. Yes, it's thanks. More work, but it's really useful to know, just because we need to learn. These are the things we need to learn rather than just make assumptions about. I know there's another question that came up, and this may or may not be a quick one to answer, is around the age-old question is, what is a non-complex dysphagia patient? Discuss. So we're back to this decision, but that might, I don't know what you did, but whether that's a sort of
I think It became less of an issue for us in one sense because we had so much opportunity to work with non-complex clients, you know, so students who were going out onto stroke rehabilitation wards. You know, in many cases, they're not complex cases in terms of the clinical dysphagia that might be present. And it can be done in such a lovely holistic way, looking at the communication side of things as well. We didn't often end up with students going out to purely an ICU setting and expecting that that's where they're going to get their dysphagia, you know, competencies. Often it's that the dysphagia placement is part and parcel of quite a regular clinical practice setting for speech and language therapists. And again, some of the more complex cases, they may be seeing aspects of that, but with their practice educator supervising or taking control. To some extent, that wasn't as much of an issue. I think practice educators themselves had a sense of what they felt was the more complex that they wouldn't necessarily want to hand over. So that wasn't, I'm not sure if Liz, that's maybe the same for you, but that wasn't as much of an issue for us. And we do have the same clear criteria in our RCSLT position paper statement around what is a complex versus a non-complex case. So there was that to kind of reference as well.
Mm-hmm. Is there anything you'd like to add, Liz, or is that about right?
Yeah, no, it's fine. I think sometimes when you get younger, newer clinicians, they think everything is complex, which it's not. You know, you do have to come back to, will the students with their basic clinical swallow exam, their basic therapy knowledge, will they be able to manage what this patient is presenting? So it's coming back to thinking what skills they have. Can they use those skill sets with this person? Or are they going to need to understand ventilators and things? That takes it to advanced. And it's just sort of also having that person with them going in and ready to step in if something does become complicated. That's what the clinical educator is there for. But yeah, it's just, there is a large number of our patients that we see is non-complex, so it's not hard to find enough replacements.
Absolutely, yeah, that's really useful to know. And moving on from that, there was a question came through about whether it involves pediatric dysphagia as well, whether you include pediatric dysphagia units as well as adults. Well, because at the moment, especially in the UK, it's kept very, very separate and specialist as a piece of work. But sorry, Liz, go.
Yeah, we have 8 hours of preparing them for non-complex management. You know, teaching them about positioning, pacing for bottle feeding, breastfeeding, the general, the basic things. But once they go into the workforce, yes, there is more advanced paediatric feeding for complex case management. That is another one of our workforce competencies.
That's really helpful. Thank you very much. Is that the same with you, Áine?
Apologies, I actually got distracted here because I discovered I could see the questions and I couldn't see them. Apologies, can you ask me that again? Sorry for that lack of professionalism on my side.
Look, amazing what you can find. It's all good. There's no problem at all. I'm very aware of time. I have one more question for Beverley, if I may, which is something that you said right at the beginning, which really caught my attention, mainly because we've already touched on it before, but if you've got any more information on it, thinking about the clinical practice educators, and if you could just pick out a little bit for us the difference between the placement tariff and the SIM tariff, and what would that mean as a clinician or for a student, actually?
Oh, I go over the killer question at the end of the evening when it's time to go home, Judith.
I'm terribly sorry. I just couldn't resist it because we were all here.
Absolutely.
And if it's too much problem, put it in an email. So,
no. So basically, the placement tariff is how much money you get paid per student week, effectively. Whether you do that in a university or whether you do that in a practice placement setting in the future, so long as it counts towards, and again, taking the point completely about hours versus capability, we're really looking at people being able to achieve their competencies or capabilities in that time frame. And what we will be doing is looking at, before, you really only got placement tariff if you delivered that capability learning in a clinical hospital, whatever based setting. In the future, we will make sure that that placement tariff is available into the universities too, to make sure that that's what we're working towards achieving, to make sure that colleagues who, either because we are in the middle of a pandemic, can't deliver their training in a hospital setting, or because actually that is the best place to undertake that training as part of the requirement of the clinical training program that people are on. There's a technical issue to it, Judith, about making sure that we're counting the placement hours that are needed to attain your pre-registration capabilities, but we can go into all of that detail over time. The bottom line is it just means that we can now respect the cost of delivering simulation in a university setting as part of clinical delivery of learning, not just what you would have done anyway beforehand. So there is a difference.
Okay. Yeah, but that gives more flexibility, doesn't it? But there was a question that came through. Can I clarify that's just for England? Are there separate
I can only speak for England. I'm sorry, colleagues from the other 3 countries. I'm an English creature with only the English perspective.
We could dig around and see what else there is in the nations elsewhere. Now, I am hugely aware that number one, we have overrun, and it is now very early for you, Liz, and probably quite late for us. And there are some other questions that we haven't got round to answering. Can I ask colleagues who have been speaking is whether we could send them off to you and get back, and we will then disseminate those answers out to anybody who's interested to listen to later date. That would be fantastic. And finally, I would just like to thank once again the wonderful speakers on this webinar today. Apologies, I fell off as well. My Zoom didn't like it either, but we got there in the end. It was, from my point of view, it was very well worth it. I've learned a lot. It's given me a lot to think about taking this project forward in England and in the UK. But I'm very heartened to know it is possible, because there is living proof on the line that it is possible, and it is a very exciting thing for us to do. So can I please thank all of you very, very much for your time and your thought and your energy in all of this. We will be in touch again, because now we know how to contact you if we may. And thank you all very much, and I will say goodbye now, and thank you all for your time. So good night or good morning where you are.
Okay, yes, thanks.
Take care all. Thank you. Bye-bye.